Hello, future doctors. Welcome to today's high-yield revision module. Aaj ka session is going to be absolutely packed with essential stuff. We're taking a deep dive into postoperative fever and wound infections. देखो यार, exams के point of view से, whether it's your MBBS profs or your NEET PG, this is a total goldmine topic. Direct MCQs आते हैं यहाँ से. I am super pumped to break this all down for you today. Okay, let's dive into this and clear all your fundus.
Okay, तो ये रहा हमारा roadmap. We'll start with the timeline of post-op fever, move through major complications like DVT and burst abdomen, then intra-abdominal abscesses. After that, we'll cover surgical site infections, wound classification, and finally, how to prevent these infections. Let's get right to it.
Section 1. The timeline of post-op fever. Knowing the day-by-day causes is basically a cheat code for clinical scenarios.
Imagine a patient in the post-op ward, and they spike a fever. The absolute very first question you need to ask is, कौन सा post-op day है? This timeline is crucial. Day 1 fever, think atelectasis. Day 2 to 3, it could be pneumonia, phlebitis, or a UTI. And just a quick side note, UTI is literally the most common hospital-acquired infection overall. By day 4 to 5, we start worrying about surgical site infections and DVT. Day 6 is a classic time frame for a burst abdomen. And if that fever is stubbornly persisting to day 7 and beyond, you have to hunt for intra-abdominal collections. एकदम rhythm में याद कर लो इसको. Day 1 to day 7.
So let's zoom in on day 1, atelectasis. Basically, क्या हो रहा है? It's the collapse of the alveoli. The patient is in pain, they're taking shallow breaths, and those tiny air sacs just shut down. This is the absolute most common cause of postoperative fever on post-op day 1. Burn this specific day 1 fact into your memory, guys, because it is an all-time examiner favorite.
Of atelectasis हो गया, do we have to treat it, right? But prevention is always better. कैसे prevent करें? The real hero here is the incentive spirometer. You know, that plastic device with the 3 balls inside that you ask the patient to blow into? That keeps those alveoli wide open. But wait, they won't use it if it hurts, so adequate pain control is a must. Also, be proactive. Treat underlying issues like CHF and COPD before surgery, use steam inhalation, and make sure they stop smoking at least 4 to 6 weeks prior to the operation.
Moving on to Section 2, DVT and burst abdomen. These are the major heavy-hitting complications.
Look, deep vein thrombosis is basically a silent killer. Prophylaxis is everything here. Mechanical prophylaxis main, the golden rule is you have to make the patient walk. Early ambulation prevents stasis. Bed pe mat pade rehne do patient ko. We also use pneumatic compression stockings to keep the blood moving. On the pharmacological side, what's our weapon of choice? Low molecular weight heparin, or LMWH. It's straightforward and extremely effective.
Now I want you to imagine this exact clinical picture. Your patient is on post-op day 6. Suddenly, the ward nurse frantically calls you, saying the abdominal dressing is completely soaked with a pinkish, serous, or salmon-colored fluid. This salmon fluid sign kya hai? It means that under the skin, the rectus sheath has actually opened up. The wound has given way. This is a burst abdomen and it's a huge emergency. Management ke steps ekdam clear hone chahiye. Right at the bedside, your emergency step is to gently reposit the bowel. We often use a sterile Eurobag or a Bogota bag laparotomy to protect the abdominal contents immediately. But the definitive fix, that happens in the OT. You have to resuture the rectus sheath. And जब ही suture करोगे, you must follow Jenkins' theory. Exam में बार-बार पूछते हैं ये. Jenkins' theory states that your thread length must be a minimum of 4 times the length of the wound. Absolutely रट लो इसको.
Let's move to Section 3, intra-abdominal abscesses. This is where we look at those day 7 and beyond complications. So, we are now on day 7 or later, the fever is persisting, the patient is having chills and rigors. What's going on? This strongly points towards hidden pus collections, intra-abdominal abscesses. And here's the cool part. The site of the abscess directly dictates the clinical symptoms. Agar pus subdiaphragmatic space mein hai, it irritates the diaphragm. That phrenic nerve irritation leads to hiccups and referred shoulder pain. Maza aaya logic samajh ke? On the flip side, if the pus is sitting low in the pelvis or the pouch of Douglas, it irritates the nearby rectum and bladder. तो patient को pelvic diarrhea होगा, which is mostly mucus and increased urinary frequency. You can literally diagnose the site just by listening to the symptoms. Okay, so you suspect an abscess. Next step क्या है?
The absolute gold standard investigation of choice is a CCT abdomen. It lights up exactly where that heterogeneous collection is hiding. And management? Thankfully, it's usually minimally invasive now. We typically do drainage with a pigtail catheter under USG guidance. There is usually no need to open the abdomen all over again if you can just drain it percutaneously.
Section 4. Surgical Site Infections. Let's get down to the basics of the actual wound.
Timing is the key detail here. By definition, an SSI occurs within 30 days of the surgery. But wait, अगर आपने कोई implant डाला है, like a hernia mesh or an orthopedic plate, this window extends all the way to 1 year. What are the types? It's just simple anatomy. A superficial infection is above the fascia. Deep is below the fascia. An organ space? That's a collection deep inside the actual organ or cavity we operated on.
We rely on a couple of scoring systems for these wounds, the asepsis score and the Southampton score. Honestly, guys, for exams, just focus your energy on what the asepsis acronym stands for. Is there additional treatment required? Serous discharge, erythema, purulent exudate, separation of tissues, isolation of bacteria, and has their hospital stay prolonged over 14 days. Southampton is more about grading the physical appearance of the wound from a 0 to a 5. Next up, Section 5, the classification of surgical wounds. This is a guaranteed Viva question. Let's walk through this matrix. Class I is a clean wound, like a standard thyroid or hernia surgery. The SSI risk is super low, barely 1 to 2%. Prophylactic antibiotics could usually कोई role नहीं है यहाँ unless you're replacing a foreign body, like an implant. Class 2 is clean contaminated. You open the GI or GU tract, but it was controlled with no active inflammation. The risk jumps a little to 6 to 9%. Class 3 is contaminated. Think of an emergency cholecystectomy or an accidental bowel spillage. Now you're at a 20% risk. And finally, Class 4 is dirty. There's already frank pus, peritonitis, or neglected trauma. Look at that SSI risk. It shoots massively up to 20 to 40%.
Time for some rapid-fire, high-yield exam pearls. These are the golden rules of wound management. The golden period for suturing traumatic wounds is 6 hours. The decisive period, which is that critical window between making your skin incision and bacterial colonization taking hold, is 4 hours. And a very practical rule for any hospital. In elective OT lists, clean cases are always posted first. You do this to prevent cross-contamination from the dirty cases later in the day. Final section, Section 6, Preventing Surgical Infections. Let's talk about what we control. As a surgical team, what is entirely in our control to stop these nightmare complications before they even begin? The single most important factor: hand hygiene by the surgeon and staff. Count the 5 moments out on your fingers with me. Number 1, before touching a patient. Number 2, before a clean or aseptic procedure. Number 3, after body fluid exposure risk. Number 4, after touching a patient. And number 5, after touching the patient's surroundings. It sounds so basic, right? But following this literally saves lives. Now, what about prepping the patient's skin? Listen closely. A hair clipper is the absolute best method for hair removal before surgery. Shaving? Absolutely not. Shaving is basically banned nowadays. Why? Because those razors cause tiny microabrasions on the skin. These invisible cuts act as a perfect breeding ground for bacterial colonization, which completely shoots up your SSI rates. And when you clean that skin, remember that chlorhexidine with alcohol is the superior agent. Lastly, let's look at the actual environment of the operation theater. The OT must have ultra-clean laminar airflow using HEPA filters. These amazing filters are 90% efficient at pulling out particles larger than 0.5 millimeter. The optimum temperature should be kept comfortably cool for the surgeons around 18 to 22 degrees Celsius. But wait, patient ko ठंड नहीं लगनी चाहिए. You have to avoid patient hypothermia by using a forced air warming blanket, widely known as a bear hugger. Keep the relative humidity dialed in at 50 to 60% and always maintain positive air pressure inside the OT. This ensures that when the doors open, unsterile outside air doesn't rush in.
All right, future surgeons, that brings us to the end of today's deep dive. Let's lock in this learning right now with a quick revision MCQ. Tell me, what is the most common cause of post-op fever on day 1 and what specific device prevents it? Think about it, shout it out, or scribble it in your notes right now. Did you get it? It's atelectasis, and it's prevented by the incentive spirometer. I really hope all your concepts are crystal clear now. But before we go, here is something to chew on. What happens when all these prevention methods we just talked about fail and we find ourselves battling multi-drug resistant superbugs right there in the OT? Now that is a massive topic for our next session. Keep studying hard, review your notes, and I will catch you in the next